meeting just, that was the last meeting before the year. Just in time for the
Yeah, no
job.
meeting after that one. Huh?
No, there was a meeting called Jim. Jim was there in February. After that, there is no meeting.
Good point. You're right.
Yeah. So how is the? I think in the States the situation become worse now.
You know, in some states like Florida is really bad. So we had a lot of, you know, it's like the third, if it was a country, it would be the fourth country in the world. Horrible cases. So, you know, what can you do? Working on it.
Yeah. Oh.
How are things over you're in Jeddah? How are things there?
Yeah, it's become better. It's improving, but the case is severity. The case severity is less.
Yeah.
The number almost 3,000 per days or 4,000 sometimes.
Yeah.
We hope the second wave it will not be bad. So because I don't want to be like Florida again. We stuck here for 6 months now. We cannot leave.
Yeah. No, I agree. It's a crazy times for everyone.
Kumar.
We are going to start.
Yeah, can I ask to start by my case because I have clinic and it's very busy and I have to go and come to you back. It's possible, Manus?
Okay, Manus.
Yeah, fine by me. Sure, of course.
Okay, just I will introduce 2 minutes and then we will actually start the program. Actually, just wanted to tell everybody that this is actually a CHIP CTO session for the program, which will be done by us. 3 sessions will be there. The first one will be today, and the second is on day after tomorrow. That is actually a live CTO, live complex case. And next Tuesday, we will have a CTO session. So we will have excellent moderators and panelists this time. We have Dr. Manos Brulakis, you may be knowing that he is one of the most renowned interventional cardiologists. He is actually the chairman and the cardiovascular director in Minneapolis Heart Institute. He will be known to many people by the book Manual of CTO Intervention, by step, and Manual of Complex Intervention. He has trained, he is basically from Greece, and after he's doing his medicine qualification, he went to US and did internal medicine and cardiology and interventional cardiology training in Mayo Clinic. And he has pursued research also in Mayo Clinic, and he has more than 600 publications. And he is a great personality, and everybody will be looking for hearing from Manos. Next is actually Khalid Tamam, a good friend of mine, and he is actually doing an IMC Live every year, which attracts a lot of people, and everybody in the Middle East and Egypt and even in Japan knows Khalid for his excellent skills in intervention. And he has done one CTO. He attended in our program in HyBiz CTO once. We were very thrilled by seeing his CTO skills. We have Gopi coming from Fortis Heart Institute, actually Director of Cardiology, Fortis Heart Institute from Bangalore, and Devinder Rao coming from is a young interventional cardiologist, very known for his structural heart intervention, and is coming from Jaipur. And Anand Janraj coming from Chennai. He's actually an aggressive C2 interventional operator from Chennai. And lastly, I have to tell about Dr. Chin coming from National Heart Institute. The first session will be starting just now and will be taught by our great friend Khalid Tamam, who will be talking about just a live inbox case for an antegrade CTO. Please, Khalid.
Thank you very much, Dr. Kumar, for this nice introduction. And I would be pleased always to be with our Indian friends and our worldwide. I will not. I will go fast. So let's share my screen. So this one of because this time Dr. Kumar advised us to do antegrade sessions for starting CTO, and this is a very good example of wire escalations has been done by me and my friend Awayid in 2018 during IMC Live. So let's start to the. Can you see my screen now?
Yep.
Okay, so it's to be quick. This a 53 years old male patient known to be diabetic, hypertensive, dyslipidemic, ischemic heart disease. He had been diagnosed before as a multi-vessel disease. Left system was fixed, including LAD, LCX, and remaining, that's very long lesion, as you see by CT, that's the RCA. And here is a control coronary angio. That's LAD, patent circumflex, and ramus, also is patent. And we also, I will show you now the RCA bilateral injection, which is very long, calcified, diffusely diseased distally RCA lesions. So next, I would like just to maybe to, as you see here, he has a 2 CTO segment, very long. He has also good retrograde. So this can be very good case as well by retrograde, if you agree with me. We start by bilateral approach, bilateral femoral, 7 French, 7 French. So this our, before to start, so when we see this kind of lesions, usually we have to think about many strategy, about the wire escalations, antigrade or retrograde, maybe ADR. All option is available in this case. EDR also is a good option because we have a quite good landing zone, but still it's very long, but the landing zone is it's okay in these patients. Retrograde options is not clear by this image, but I will show you he has a very good septal collateral, in spite that he has some jailing of the collateral of the stent. This patient has some left main disease, so we have to be careful all the time when we engage. So because again, this is a wire escalation, so always we have to start by antigrade because this first attempt. This GCS score is 2 to 3, so it's a long lesion, calcified, and blind stump, so this is a 3 GCTO scores. So I decided in this time to start by antigrade. So always my wire escalation, I start always with a good backup support guiding, 7 French or 8 French for bilateral femoral approach. Sometimes I use femoral radial. And then we start with wire escalation, starting with Felder XTR. So always I start with Felder XTR. Why Felder XTR? Because it's a very soft tip load wires, not injuring the as a first attempt, not starting with a very stiff wires to have the failure would be more stronger. And I'm using here, as I remember, this is a Microcatheter fine cross, because also the soft one. So here's the Felder XTR, and we try to negotiate the entry of the microchannel. Again, but during this time, we have a damping of the donor artery. As I say, as you can believe here, it has an ostial left main, distal left main disease. So we decide at that time to put a wire just to keep the guiding stable without injuring the left main. If you see here, this is a Felder XTR. Try to negotiate with this long plaque. However, is not working well. My tips in the Felder XTR, always Felder XTR, if it's going straight, it's mean you are in the true lumen or the true somewhere, but it's not. If it's not doing loop, it's mean you are still in good channel. You are good somewhere, or side branch, or you are in the bridging collaterals, or you are in the true lumen. So it's not, again, you are not in the false lumen. If this Felder XTR have a loop, it means you are in the false lumen. I don't know, Manos, believe it's agree with me in this point or not.
That's a good point. I mean, to be honest, I think here many people just use this for like a minute. So you put a Felder XT, and if it goes easily, you continue, as you said, and if it dips straight, then you're more likely to be true lumen. And if the tip bends, it is. But I think many people don't try to use it for too long in the US. They just use it for a minute or two. If it doesn't work, then they just switch for something stiffer like the Pilot 200.
Yeah. So little bit with Manus, but Pilot again, it's for me, it's a very hard wire. So I know that they are loving because you are a center of excellence of ADR. So you are always have other backup support or peel out techniques to go even by ADR direct. So, but this case was not an option for ADR. So, and this time, because it's again, sometimes the cost. So I'm trying my best to do by Filter XTR, and then I'm upgrading to go with a Gaia. So here, because the other, as I told you, the other donor artery was damping the pressure, so we was afraid to for left main. So because always the pressure was ventricularized, so we put a wire in the left main, just put the guiding out and secure the place and you work base in peace. So always you have to take care about your donor artery. So it was one of the steps. And then we go back to work again. You see the filter XTR is going somewhere, but here at this point, stop in this point, and we should change with penetration wires, which is I always change with Gaia. So once, for my strategy for wire escalation, once Gaia has been penetrating your CTO, I'm de-escalate again and going with filter XTR again, or going with something less stiff than Gaia. As you see here, as you believe this, it's mean you are in the, something need to have a good penetrations. Retrograde, we are completely outside. And at this time, the Gaia has been broken, so I changed with another new Gaia. Sometimes you can go with Confianza Pro 12. As you see here, also the tip load of Gaia is very easy to be broken. Now we have a Gaia next, which is more controls. And yeah, as you see here, you believe it's going somewhere. So we have to have a contralateral injection.
This is the lateral view you're using right now. It looks like a very nice view for opening up the right coronary.
Yeah. Here's the RAO cranial, or this epicranial, because if you see the screen. Okay. So we are a little bit away. It's mean like is in the branch, it's an RV branch. So still the right coronary artery is a little bit behind our place. So we are in the RV branch. So I have to go back. So we go back, we try to go, it was at the RV. So I tried to redirect the tip of the wire to go. And this is very important if you have a wire escalation, that's if you pull back your wire and it's very stuck, it means you are in the truly human. Sometimes the wire going very smooth, but if you pull it, if it's subintimal, it's making like this pull backing snitching of the wires. So here the wire is going in the direction what I want to go, it's laterally. Again, I try just to. So I advance a little bit the microcatheter and I change with the new Confianza Pro 12 just to have a good penetrations. Maybe I have to pull back my microcatheter. So here it's moving. Yeah, here is a better direction. We have to have a controlling of the we're still here in the same with a filter XT with a Gaia with a sorry with Confianza Pro 12, and you see it's still outside. Now the Confianza Pro 12 was able to cross, and we went back down to the good distal through lumen. And it's already passed. At this point, you have to de-escalate again, and we check by IBIS. We have a small dilatation, and we check by IBIS to make sure that we are in the true lumen. And then we stand. And here is the final image. So if you summarize to do that, we start with a wire escalation, filter XTR not working, then Gaia second not working, then Gaia second again not working, then Confianza Pro 12 finally it worked to penetrate the distal through lumen. And then I think I de-escalate again to filter XTR. And then finally we get a good vessel at the end. And finally, we stand. We have better controlling to the ostial. And I think this is the end. Yeah, it was the end. Yeah, this was the end. Thank you very much. That was the end of this Latin box. So Manos, do you have any comment?
I think this was a great case, and I think it demonstrates the importance of trying undergrade wire escalation first. Many people might have said, look, this is a very long occlusion. It is 70, 80 millimeters long. So we'll go primary retrograde, which, as you said, did have issues because you have disease in the left main, you may cause ischemia. So it's always, I think always, in the vast majority of cases, it is a good idea to first try to go undergrade. And then if it doesn't work, you can always bail out. But I think this is a good example of how escalating, de-escalating, checking orthogonal views, you can actually cross even very complex long CTOs with significant calcium. So I think congratulations, it was an excellent demonstration of undergrade wire escalation.
I think, I have a follow-up of this patient. Maybe at the end of the seminar, I can show you she has a follow-up of this RCA, which is huge. After 1 year, the left main has been severely stenotic. And the one who's saved this artery, this guy is RCA, which has become huge dominant artery. Big one has surviving all the heart. So it was good.
Khalid, I have 2-3 comments to make. One is actually during escalation, if you have a chance of not crossing the wire antegrade, then you can keep and take a double lumen catheter and take a second wire and try with the parallel wire, if at all not crossing with the first wire. Your wire was a little bit outside in the middle part of the CTO. So that segment, you could have taken a double lumen catheter and take another wire down and cross the CTO. What do you think? Which are the situations?
Yeah, I think parallel wire techniques, it's before having the double wire microcatheter, we use to have a parallel wire techniques a lot. And then we stop, then coming back again when we have the double lumen microcatheter, which became the life easy. Actually, I'm not doing so much. If the thing is not working, I switch to retrograde. If it's not working, it's more easier than double wire. Usually it's not working so much. but sometimes it's okay. Yes, it's working.
Okay. I think if no more questions, Manos, we can go to. Thank you, Khalid. We will go to the next presentation by
Yeah,
Dr.
I will leave you for a while and I come to you back. Okay.
Thank you. Thank you.
Thank you. Okay.
So
Thank you,
Manos
Manos.
giving on the global perspective of CTO. So that will be a great talk people will be hearing for. Just.
Wonderful. Yeah, thank you very much. I would like to thank Dr. Pratap Kumar for the opportunity to be with you this morning and speak on something that is very dear to me and many people, I think, around the world, which is that now we're reaching a consensus on how to approach chronic total occlusions. There are some common principles that many people are adhering to, not only in one country, but around the world. These are my disclosures. And it's interesting that the number 7 does seem to have a special meaning. As you know, we do have 7 days of the week. There are 7 habits of highly effective people, and there are 7 deadly sins. So it can be good or bad, but the number 7 has something with it. And these are the 7 global principles for CTO intervention, which I think, although we do have still some areas of controversy and different regional preferences, but overall, pretty much everyone agrees on these principles. And those are, first, that the principal indication is to improve symptoms. Second, you have to do a dual angiogram and look at the angiogram carefully. Use a microcatheter. All the strategies are valuable in the right setting. And then changing increases the likelihood of success. This should be done in centers and experienced operators. And then finally, that once you finally get through and you put your stents, you should take the time and optimize the stents as much as you can. And this is also reflected in the 14 steps of PCI. These are the steps that are common to every PCI procedure we do, starting from planning all the way to use of hemodynamic support. And the ones highlighted are especially important for CTOs, and we'll cover them one by one down the line. So the first one is about the indication. Even though CTO might help in other settings, the number 1 is to improve symptoms. Several studies have been done. The one that has the most weight is the EuroCTO trial that randomized 400 patients to either CTO PCI and OMT versus optimal medical therapy alone. And what was found is that the improvement in quality of life was significantly better with CTO intervention versus not. And actually, Gerald Werner presented the long-term follow-up at TCT last year, showing similar safety. As you know, Decision CTO, the largest CTO trial, did not show any difference in symptoms, but patients were mildly symptomatic, and there was a 20% crossover from medical therapy to CTO PCI. And the 2 other studies were actually not symptom-wise, but they were studies looking at ejection fraction that did not show change in ejection fraction. So CTO PCI should be done when the benefits are more than the risks, and the benefits are to improve symptoms. Of course, to get the benefits, you have to be successful, and that depends on the complexity of the lesion and the experience of the operator. And of course, the benefits should outweigh the potential risks, both in the acute as well as in the chronic setting. Moving on, dual angiogram is the key of CTO PCI. As you've seen in the case from Dr. Tamam, dual angiography is critical for understanding exactly where the lesion is, but also crossing the lesion. What access do we use? It used to be bifemoral 8 friends for most of the cases. We have now evolved, and actually many centers use femoral radial or biradial. In the most recent Progress CTO, about 2/3 of the lesions were actually done using radial and femoral. And it's been actually 21 years since the first report on dual angiography. So this is something that's been there for a long time, well established. If there's one thing you should do for every CTO PCI or almost every CTO PCI, this is it. Put the second catheter in and do the dual injection. How do you do it? You use a low mag so you can see the entire heart. And then you inject the donor vessel, which is the LAD in this case, the left main. Wait for a couple of seconds and then inject the occluded vessel. And then you can see the collaterals, you can see the vessel filling, you can see the length of the occlusion. That helps you facilitate the planning. And you want to actually do long injections. You don't want to stop seaming. You want to actually take your time and look at this very, very carefully. There are 4 things that we look at, which we'll go over in the next slide. But ideally, everyone in the cath lab should look at the angiogram. The fellows, the nurses, the techs, if there are any industry reps, all of them should sit down and look at the picture. And it's not an exaggeration saying that you want to look at this for 15 to 30 minutes. It does take some time to familiarize yourself with the CTO. And what you see at 30 minutes is much different than what you see at 5 minutes or even at 15 minutes. So the longer you look at the picture, the better you understand the CTO, which might be the difference between success and failure when you get in trouble and your strategies don't seem to work. And then what do you look for? There are 4 things. The first one is the proximal cap, or where the CTO starts. The second one is how long is the lesion. The third one, the quality of the distal vessel. And the fourth is the presence of various collaterals. And this is an example of how dual angiography can help. This is an RCA CTO. We can see that the wire here has gone in the subintimal plane. This was a case in which we tried to use a Stingray balloon for re-entry. And before puncturing it, we took another picture. And if you can see here what has happened, the wire has migrated into an acute marginal. So if we didn't have the dual injection, we would have tried to re-enter into a small branch, potentially causing perforation and complications. But not only that, they were able to redirect and go in the course of the vessel, but even for putting the stent in, by doing the contralateral injection, we were able to park the stent just proximal to the PDA, PLV bifurcation, and as a result, avoid compromising the distal bifurcation. So dual injection is probably the most important parameter, the most important factor for getting success and safety for CTO intervention. Now, when you look at the angiogram, many people like to calculate a score that gives you a sense of the difficulty of the lesion and also the likelihood of being successful. The oldest score and the most commonly used is the JCTO, or Japanese CTO score, 0 to 5. The 5 parameters are tapered or blunt proximal cap, calcium, more than 45-degree bend, and more than 20 millimeter CTO length. The 5th one is previous failure. And the higher the number, the less the success. And actually, it takes longer to cross the CTO. So for JCTO 3, 4, and 5, it's very unlikely to cross it within 30 minutes. There are different scores. This is the progress CTO score. Similar concept, proximal ambiguity, interventional collaterals, tortuosity, and circumflex seems to be the most complex type of CTO. And the reason this is important to calculate the score, especially early in your learning curve for CTO intervention, is because you can then choose the lesions you want to do. When you're starting, you want to start with the JCTO 0 to 1. You don't want to do these lesions, JCTO 3, 4, 5, because your chance of success is less and you're more likely to get in complications. And nothing kills a CTO program more than having complications or multiple failures in the very beginning. So when you're starting a CTO, if you're an early operator, start first with the simpler cases, get some experience, and then move on to the more complex cases. As you saw also in Dr. Tamam's case, there is increasing use of CTA, coronary CT angiography. If you have that, that's a great tool. We do it quite often, especially for the complex CTOs and the ones with previous failures, because it actually helps you understand better the morphology, the calcium, the length of the lesion, and actually it predicts better success than the angiographic review of the films. Here's an example of a nice CTO. This is a nice, clear, tapered proximal cap. There is no calcium in the occlusion. The occlusion is short, and there is a beautiful, large distal vessel. This one is going to be much easier to recanalize than this CTO, which has significant calcium. There is side branch on the proximal cap. The distal vessel is diffusely diseased. You can see the calcium is essentially circumferential. It's like the full vessel is completely calcified. So these CTOs are much harder to treat. Going on to the third principle, which is use of a microcatheter. You can use if you don't have a microcatheter, you can use an over-the-wire balloon. The downside is that the over-the-wire balloon has the marker in the middle. So you don't know really where the tip is, because what you're seeing is the marker and you don't know how much further down the tip is. Also, the balloons are stiffer and as a result can be a little harder to manipulate and more likely to kink. These are the various categories of how I like to think about microcatheters. And I like to group them into 5 categories as big, small, angulated, dual lumen, and plaque modification. The big ones are the Corsairs, the turnpike spirals. So these are microcatheters that have a thicker shaft and provide you more support. The smaller ones can be like the Caravel, the Turnpike LP, the Fine Cross. Those ones are more flexible. They're sometimes easier to go through small collaterals, but provide you less support. And unless you have the Turnpike LP or the Corsair XS, you cannot torque them as much because of the risk of tip separation. The third category, very, very useful for circumflex CTOs or when there's a big angle, are the so-called angulated microcatheters, like the Supercross, the Venture, of the Swift Ninja. The fourth one are the dual lumen, Sasuke, Twin Pass, and these are very useful when you cross into a side branch and you don't want to lose your wire position. By using a dual lumen, you can keep your wire position into the side branch and then use another wire to go into the main vessel. And finally, there's the Tornus and the Turnpike Gold, which are used if your wire goes through, but then a balloon cannot follow. These microcatheters modify the lesion and help with subsequent crossing. Number 4, for the key principles, it's to use all CTO crossing strategies. To get the best success, you need to be familiar with all types of strategies, because sometimes multiple strategies don't work and vice versa. Now, there's nothing wrong in being an undergrade only operator, but then you should accept that there is a slight higher chance that you will be unsuccessful than if you have retrograde skills as well. So everything is good, everything has its role. There is no better or worse strategy. And if you look at recent registries, this is from Richards, all the strategies were necessary. If you look at the successful technique at the end, about half, it was undergrade wire escalation, and about a quarter was dissection reentry, and about a quarter was retrograde. So you need all the strategies, and the easier CTOs you'll be able to recanalize in most cases with wire escalation. Of course, even some complex ones, like Dr. Tamam's case, you can recanalize this way. But as you get more complex, then you're going to need more and more to use retrograde and undergrade dissection reentry. What we have seen is that the various algorithms regarding which technique you should choose or not have been converging. The hybrid algorithm, the EuroCTO, the Asia Pacific, they're all very, very similar in the way we approach the lesions. And then if you're a beginning operator, once again, you start first with undergrade wire escalation, then you go to undergrade dissection reentry, and then you add retrograde through septals, and then finally you get retrograde through epicardials. So this is one way for learning. You start with a safer and simpler techniques, and then you build your skill set by going to the ADR, and then retrograde septals, and then through epicardials. This is the fifth key concept, which is the change. Many years ago, back in 2009, 2010, we were starting to learn more about the approach. The common theme was you find the CTO, you try for 3 hours wire escalation, and then if it doesn't work, then you bring the patient goes home, comes back in 2 months. Well, not anymore. Now we want to change and do this quickly during the same case. This is from our early experience in the change. You can see many cases are actually successful directly by the first approach, but many of them require 1 or 2 or more changes before success is achieved or before we give up. So in this series, almost half the patients require the change of approach before a final success was achieved. And the same thing is seen in progress CTO. We see that quite often what you start with doesn't work, and then you switch to a different strategy before you finally get to success or not. Your chance of success depends on the complexity of the lesion, with JCTO 0 having much higher success than JCTO 5. But also, what changes is the more complex the lesion, the more the need for retrograde in yellow and ADR in light blue than in the simpler cases. So again, if you have JCTO 4 or 5, don't try them unless you have good skills in retrograde and undergrade dissection reentry. Now, the key concept number 6 is about who should attempt those cases. And there is increasing awareness that this is not something that you do as an infrequent event. Like everything else, the more you do, the better you get. So to get the better results, what you want to do is to do a lot of those cases. And that is why it's best for this to be done at experience centers. You see at the experience center series, success is between 85 and 90%, with about 3% MACE. But then if you look at more general registries, success is actually much less. This is from NCDR, which is a United States broad PCI registry. Success was about 59%. And if you look at England and Wales, success is also in the 60% range, although there's some increase over time. So the more experienced centers do get better results. If it were me having a CTO, I would like to have it done at a center that is experienced in doing this procedure. And same thing for NCDR. The more you do, the better you get, the more success, the less complications, simple like that. So one of the challenges now, and I think this webinar and many other resources, books, websites, meetings, the goal is to bring people from here all the way to the experience centers to the 85, 90% success. Now, people are asking, what about 100% success? Well, what happens is, I think after 90% or so, your complication rates go way up if you try to go for the 100%. So at least at this stage of things, being 90% or so, it's pretty good. And sometimes pushing very complex lesions and dangerous epicardial collaterals may not be the best thing for some patients. Now, the other reason that you want to do this in experience centers is so that you have equipment and experience in handling complications. There is no question CTO PCI has more risk for complications. And perforation is one of the most feared ones. And there's different types. As you can see, this is from CTO ARC, a combined approach that is currently being reviewed. And what you want to have is covered stents for large vessel perforations like this one. Papyrus is one of them. And you want to have coils for distal vessel perforations. And ideally, you want to have 0.014 coils, because those can go through your standard microcatheter without needing to change for a larger microcatheter, as is the case with other coils. And also, I would encourage you to create a CTO/complex PCI card. This is the card in our hospital. So have the short wires on the top shelf, the long wires in the middle shelf, have various microcatheters and specialty balloons like the Sapphire on the third one. And on the bottom, we do have the coils and the device for deploying coils. So having all of this in one card does many things. First, it's faster for the staff to give you the equipment. You want a wire, you don't have to go to the other room and get the wire and bring you back. So it's very, very quick. Second, if a complication happens, you don't waste time. You have the equipment here, you can use it right away. So having everything in one helps everyone to be more efficient, less frustration, faster cases, more happy operators, and happier patients. And the seventh and last concept is about optimization of the result. And in past years, again, 10 years ago, people actually would joke about using IVUS, is it needed or not? But I think now everyone agrees that these cases are very complex, and what you want to do is get the best possible result at the time of PCI to minimize the risk of restenosis and adverse events. So imaging is critical for CTO PCI, and it's critical sometimes for crossing, for example, resolving proximal cav ambiguity, but also for stent optimization, choosing the size of the stent and ensuring that the stents are well expanded and opposed, and checking if there is any complication or not. And you want to avoid this stent anterior expansion, because this will lead to higher rates of restenosis and also stent thrombosis. We can see that the overall rates for restenosis are pretty favorable, usually in the 10% range or so. But again, they can get even better. There was a paper last week from Consistent CTO with 5%. So things can get better. You want to take the time to optimize the results. And this is the largest randomized trial to date, the IVUS CTO study that did show that if you optimize with IVUS, you do get less MACE than if you don't optimize. So taking your time to optimize the lesion is great. So this is where we currently are. We currently have less experienced centers than experienced centers. The experienced centers get about 85 to 90%. The less experienced about 60% success. And then you want to get to the 100% success with 0% complications. We're not there yet. But again, the goal is to get as many centers from here to here, and then trying to find new technologies to move it further down to the ideal center. And I always like to talk about this book, which is the peak book from Anders Ericsson, How to Become Very Good in Something. That can be anything, but specifically for CTO PCI, what you need is what's called deliberate practice. You want to have a purposeful practice, so you're getting challenged, you have specific goals, you focus on what you do, you monitor your progress, you remain motivated, but also you have a teacher, and a teacher can be a person, can be the books, can be the cases, can be everything that you are exposed to at different meetings to get you to build the skills to treat this very often highly complex lesion. So I'm going to stop here. Once again, there are 7 principles. I think adhering to those will help both the success and the safety. And of course, there's room for more improvements and more technologies to come. And again, look forward to work with all of you to move our needle so we can get more of these cases done safer and more efficiently. Thanks again. I think you are muted.
Thank you, Manos. It was a wonderful presentation. I just wanted to ask you that what percentage of cases you do retrograde and how many percentage you do ADR?
So for us, it's about 25-30% ADR and about 30 to 35% retrograde. It used to be much more retrograde before. And I think now with new wires and new equipment, our undergrade success has gone up. So we have more undergrade now and slightly less retrograde. But still, the very complex cases is quite likely to need to go retrograde.
Do you use more penetration wires nowadays? Actually, there was a question came from the chat. Do you use more penetration, or you just switch over to the other techniques?
So we do try in most cases to do escalation or undergrade wiring attempts. So our typical approach is we start with a Fielder XT or similar wire, XTA, XTR. And then if it doesn't work, then if we understand where we're going, then we often will use a Gaia second, that's our preferred second wire. If there's some ambiguity, if there's some tortuosity, the Pilot 200 or the Gladius now are good choices. And then if it doesn't work, if it's very calcified, we will use the Confianzas and the Hornets. We'll use them, and the Judas, we'll use them mainly for heavily calcified, difficult to penetrate lesions.
Okay, thank you, Manos. Due to the time lag, actually, let me go to my presentation. Next is my presentation, and after that, there will be 4 CD presentation, and I'll go with my presentation. Is it okay?
Perfect, perfect. Thank you.
Is it visible?
Yeah, looks perfect.
Actually, I will be presenting on some 6 cases of what a chip CTO does. We don't use a lot of hemodynamic support, but we do because of the country like us, we have some limitation, but I have done some cases which I just explained in the allotted 20 minutes. The first case actually a case rejected because of the raised creatinine. Second is actually because of the surgical contraindication. Third is actually a post-cavate with refractory angina. And fifth is actually patient was advised cardiac transplantation. Fifth is actually severe breathlessness with LV dysfunction in a severe COPD case. And lastly, a diffuse coronary artery disease rejected by the cardiac surgeon. Okay. The first case is actually a cabbage, a 2008 cabbage done angina for the last 3 years. The TMD strongly positive and creatinine was 1.8. And the patient actually advised angiogram done after some time, 8 years. Patient had a patent graft with osteoproximal circumflexus totally occluded and Patient was advised angioplasty that time. Patient did not do because somebody threatened him that he will go into a permanent dialysis. This was the angiogram. That time in 2016 has a significant osteoproximal circumflex, but no graft. The graft was occluded. So the patient was advised angiogram, PCI to that, but patient was not willing because of that. This time the patient came to me with a circumflex totally occluded. I could not see the distal vessel. So what I tried is actually, we kept the previous angiogram there and tried to pass first wire fill FC, which was not passed. But I tried an XTR. XTR I could manage to pass with the anatomy and with the screen, previous screen there. But I tried everything and nothing was passed. Balloon tried, failed. Tonus tried to pass, failed. Then subsequently, what is the next choice? I took a microcatheter, but microcatheter also could not cross. I took a rotor wire down. With the help of the rotor wire, you can see that when I tried to push the rotor bar with even 1.25 could not go and the wire is coming back. But with that heat generator there, I could take a 1.5 into 15 balloon, then subsequently 2.5 into 15 balloon, and with the ending of 3 into 18 stent. This was the final result and patient got angina relief. This is the first case because of the creatinine patient was rejected angioplasty. Message, raised creatinine is not a contraindication. We do a lot of zero contrast angioplasty nowadays. Next is actually a patient had an LMCA with a severe vessel disease, severe triple vessel disease, an RCA CTO, RCA territory is non-viable, but the patient with an LV ejection fraction of 22%. Patient actually advised CABG, but when they examined, right internal carotid artery was totally occluded, left internal carotid artery has a 90% disease. So the surgeon told that this will be a high-risk case for surgery. This was actually angiogram for left main. What we thought we will do an LM intervention with the pre-dilatation. Technically, it was not a challenging case, but the low ejection fraction and the carotid disease create a lot of problem. And ejection fraction was 22%. We did first kissing balloon inflation, then 4 into 26 stent. That time when we inflated the stent, its patient was going very bad. Luckily, with the inotrops, patient did another 3 into 30 stent. You can see that we did a crush there. We did a kissing balloon inflation, second KBD. Then finally, we did a pot with a 4.5 into 12. And we finished the case. After exactly 4 weeks, this is the only carotid artery left with a significant disease. You can see that in the second frame, I put a proteage stent 7 into 40, which is inflated. When it inflated itself, the patient was in a bad shape. So we did not go for a balloon dilatation. Because it is a balloon expandable stent, we decided it will go by itself. We took the filter out and finally the injection is like this. And we got a real cerebral circulation was patent. But the lucky thing is actually 3 years post-intervention, patient is symptomatically better. LV ejection fraction improved from 25% to 40% and still on regular follow-up. From the functional class improved from class 4 to class 2. The message is actually LM vessel with a triple vessel disease with severe LV dysfunction created a barrier for the cardiologist. Significant carotid artery disease for the cardiac surgeon, but for the patient, what is to be told? A hemodynamic support will definitely make a difference in this case. We clinicians have no right to reject a treatment for the patient. The third case is actually a patient is evaluated in a major hospital with a EF of 24%, and the only option they told was a cardiac transplant. This was an angiogram. LV was very bad, a CTO. We crossed with the Miracle 6 after failure with other wires. We put a stent there. Vessel is opened up with the 3 into 40 stent and another stent in the RCA. This was the RCA stent. Subsequently, we opened the circumflex CTO with a balloon, followed with a 2.75 into 40 stent. Another stent 2.75 40 into the LAD, which was a very, very bad disease. And this was the final result. Patient is, the Lucky part of the thing is actually patient completed 3.5 years, 3 years, 3 months. As on today, LV ejection fraction improved 40% and doing business and on regular follow-up every 3 to 6 months and no admissions after that. So we actually did a patient which was advised transplant. The heart transplant is the way for refractory heart failure. Moderate viability of myocardium is also important in giving a chance for revascularization. CTO or severe LV dysfunction should not be a barrier for revascularization. The fourth case is actually a 58-year-old man underwent bypass surgery for triple vessel disease 8 years back. The patient actually tried angioplasty in 2 centers, failed, increased medication. Now, the only vessel patent is actually a Lima 1280. The patient is actually having an LMCA occlusion, the circ is totally occluded. We blindly passed a Concourse Pro 12 without seeing a vessel, but we could cross the lesion. Finally, we could open the circumflex by putting LM to circumflex and OM 2 stents. But with this opening, what we achieved is actually this patient, after 3 months, we could open both the vessels very well. A significant severe disease, but we could finish the case by putting 4 stents. This is the final result of the case. So the patient is doing extremely well even after 4 years of refractory angina with a double CTO, circumflex and RCA. So CTO in circumflex and RCA when LED is normal is the situation here. Post-cabbage is another challenge. Newer guide wires and devices along with the skill of the cardiologist make a difference in this case. The fifth case, class 3 dyspnea on 10 years, and the patient is actually on COPD for inhalers. Even on room air, the patient is actually saturation is 86%, the ground glass appearance of lung. The angiogram is very terrific. This is actually the angiogram. Patient actually came with a severe angina of 1 month duration, a significant disease in the LMCA. So plan to do an LMCA 1280 done by retrograde intervention. We completed the, you can see the background lung is actually a ground glass appearance. We could do the LMCA intervention by this. So the patient was actually angina free and doing very well. Severe COPD is a challenge for the anesthetist. A CTO of LED Austin with a very tight LMCA disease for the cardiologist is a technically skilled challenge, but technology and skill make a difference. And this is the case I just wanted to explain. The patient is actually a 67-year-old politician, class 2 dyspnea, diabetes mellitus on treatment, creatinine in various hospitals in 1.8 to 2.4, ejection fraction of 22% with a global LV dysfunction with a mild to moderate MR. The patient's problems are high creatinine, severe LV systolic dysfunction, a diffuse CAD, doubtful distal target, a rejected case for both cabbage and PCI. This is the angiogram. Angiogram showing a significantly severe LED disease and the circumflex disease. And the patient actually no target vessel is good, including the RCA, diffuse, LA, PDA, and PLV. The patient actually, we explained the high risk to the patient and the stage stenting of the coronaries if possible. I plan to do a stenting of the circumflex first and see the result and then plan later was my plan. We actually passed a wire into the circumflex artery with a 7 French EBU3, a filled FC wire, 1.25 into 15 and a 2 into 50, 12 millimeter balloon. We put a 2.5 into 26 millimeter stent, and with a significant disease in the LM osteoproximal circumflex, we put a 4 into 24 stent. So finally, we put a 4.5 into 12 millimeter atmosphere in the LMCA and opened the circumflex and the OM vessels. I just kept like that and kept the patient. But after 3 months, the cardiac function is improved to 45%. And this happened in 2017. The patient wants to do other blocks also so that he is expecting a better cardiac function. I decided to do it later. By repeated request, I decided to do an angiogram. So this is the angiogram. So what actually I did, I just passed a wire. A lady was, I was not sure what vessel size it is. I just cannot pass. I just put in 1.25 into 10 millimeter balloon, then 1.5. I could not take more than 2 millimeter balloon because I was so afraid. I could not even take an HyBiz catheter down. So the stent was not able to take into the distal LAD because we have a stent from LMCA to circumflex. So what I did is actually I put a guideliner at LM to LAD ostial part. Then we decided to take a guideliner up to the ostium and then take the stent. If you watch carefully, the stent is gone through the guideliner, which is kept inside the stent of LM to circumflex. One stent actually we put 2.25 into 40, and then another stent we decided to put. You can see that the 2.25 into 36 stent actually we put through that. So we put 40 into 36, that is actually 76 millimeter of stent in the LAD. And we inflated. I was very much worried, and this was a result. I was happy and just kept like that because the patient actually have a minimal osteal disease in the LAD. I just kept like that. In 2018, July, we did a check angiogram. Patient had a mild chest discomfort. Treadmill was not done, and the cardiac function was improved. Patient wanted to have an analysis of his coronary artery. This was an angiogram. The angiogram showing is even an osteal LAD disease is there, but when I checked the angiogram with the previous angiogram, then patient angiogram was looking same. But even if I do something into the LAD ostium, it will be a tough challenge for me. So I decided that I will just leave like that. In re-evaluation in 7/5/2019, an upper epigastric discomfort, and we decided to do an angiogram with an imaging. If significant, we will go for a stenting of the ostial LAD. This was an angiogram of the RCA, similar, but you can see the LAD part, the left system. You can see the left system. You have seen an osteal disease in the LAD. This time, what we decided is actually we did an IVUS of the image, IVUS of the LAD. You have to understand that the IVUS can be done by passing a wire through the LMCA to circumflex vessel. So the distal LAD MLA was 2.2 millimeter, and we got an MLA of 3.7 in a 2.2 millimeter vessel. And the mid LAD, we got 7.2. That is the area we got, and a 3 millimeter vessel. Ostial LAD was very 4.2. You can accept it because it is a 4. We are not doing anything, but the proximal LAD is only 2.9 millimeter. So we decided to do something on that. So with a 2.9 millimeter, and the circumflex MLA is 5.6, and the vessel is nearly 4.5, with the vessel has some regrowth of the block. LMCA MLA was 9.9, and circumflex MSI was the mean stent area was 4.3. So we decided to do a pre-dilatation of 2.5 millimeter balloon into the LAD through the stent strut. Then we decided to do a tap stenting with 3.5 into 28 science expedition with a balloon there. So finally, what we did is actually we decided a tap stenting and a post dilatation of 3.5 into 12 millimeter in the mid LAD part. We did a 3.5 balloon into the LAD and 4.5 balloon into the circumflex, did a kissing inflation, and a final pot done with a 5 millimeter balloon. And we did a final LAD run of ostial LAD. We got nearly 8, and we got an LMC of 4.6, and 7.5 is the post LAD, and we got 8.2 for the ostial LAD. So the previous pre-PTCI LMCA was 9.9, and post-PCI LMCA is 11.2, and ostial LAD is 4.2, and it became 8.2. Proximal LAD from 2.9 became 7.6. Ostial circumflex, actually, we did not measure again, and this is the final result of the case. So the first case with the high creatinine was the problem. Ultra low contrast and zero contrast angioplasty is the way forward. We have done 10 cases already. Second case, LMCA with triple vessel disease and carotid. We have done the choice of doing the case by doing the case in 2 sitting with usage of is more appropriate. Actually, impeller-like device was more appropriate in the case if it is actually the finance was not an issue. The heart transplant is always a choice in a critical disease, but we should look into the other possible option even by an interventional operator under the hospital. The fourth case is a multiple CTO in a case of refractory angina. We did this case in 2 sittings. Fifth case was a severe COPD with a ground glass appearance in the lung, and the X-ray will be a real challenge for any anesthetist for ventilation. It will be a real difficult situation in a post-operative phase. Last was a very interesting case for me. A diffuse coronary heart disease, still a challenge for any cardiologist or a cardiac surgeon. My suggestion, we clinicians should not leave this case till the last moment and try all the chances. Here, attitude, perseverance of the patient and the relatives also important and still survives with a high quality of life. So I just tell you that the next program, I just finished this program by this, and actually I should tell you the next program. I just telling you in advance, the next is actually a complex situation with calcium and imaging will be the next session. I think my talk is finished. Uh, uh, Manos can have some discussions.
Yeah, thank you again, Kumar. That was great cases and actually a wide variety of cases. I think on the first, maybe talking on the first case a little bit, so the zero contrast PCI, that's emerging as a new theme for doing PCI in people who have a significant chronic kidney disease. But I mean, a couple of the things to realize, especially when you're doing a atherectomy on the zero contrast. As you know, the perforation risk is not high, but exists. So I think many people would do an echo before and then an echo after. But actually, many people advocate, and I'm a big fan of that, that if you do a complex PCI like this, it is worth to use 5 cc's of contrast and just do a final picture at the end, just to ensure that everything is okay, because I think it's what you did, and I think that's the way to go. I think, trying to go for 0-0 is, the risk might be significant. Sometimes you may need a little contrast just to ensure yourself that you've done a good job. The second thing from a couple of your cases is the response to ejection fraction. As you know, we say that the indication for CTO is to improve symptoms, but as you saw in your cases, in some cases who have significant ischemia and low ejection fraction, by recanalizing the CTO, you can actually improve the patient's ejection fraction. So that's something to keep in mind. It's not always something that doesn't happen after PCI. And then finally, on the post-CABG cases, these are much more complex. There is more calcium, there is tortuosity. Sometimes you have to navigate through the areas of the bypass touchdowns. And we've seen, for example, in progress in other registries, that success is about 6-7% less than success in non-bypass patients. So for those patients, I think this should be done with experienced centers. For those patients, especially CT before is very useful sometimes to delineate the anatomy. And then the other thing specific for bypass is if a perforation happens, that can be lethal because of loculated diffusion. So if there's a perforation in a bypass patient, then you should truly try to treat it as soon as possible to minimize the risk of this loculated diffusion.
I just wanted to tell you, Manos, actually, we have done the LMCA with the rotablator in a case with zero contrast. We have done echocardiogram before and after. I think it is published, going to be published in Indian Heart Journal. I already did an LM bifurcation with zero contrast again. And we have done 4 cases with rota in with zero contrast. 10 cases already finished. And the last case was actually my interesting case, actually, with the follow-up of 2017 to 2019, regular follow-up and angiogram. I never expected that I could do that angiogram and angioplasty of that case with a looking like 0.75 millimeter vessel by angiographically. It was a really worth case, and the patient is laughing and coming to me regularly and meeting me. That was real. This is something which an interventional cardiologist will get happiness out of it.
Absolutely.
I think probably no question will come, and I could not see any questions from the chat also. But any more questions, Manos, you wanted to tell about the cases which I presented? Or
Actually, I see there's one question on the chat about the ADR without Stingray using IVUS from Dr. Vijay Shah, and ask using IVUS dual lumen microcatheter or recross. That's a great question. Now, I realize that Stingray is sometimes prohibitively expensive in other countries, so that may not be available to many operators. And there are some cases in which we've used the twin pass, especially early on. I think the recross, if you have the recross microcatheter, for the audience, the recross has 2 over-the-wire lumens. Most dual lumen microcatheters have only a monoray lumen and a long lumen, but the recross has 2 full over-the-wire lumens. So that would be, in my mind, the preferred dual lumen microcatheter to use in case you go subintimal and you do not have access to the Stingray. So it can be done. It can be difficult. I mean, I don't want to claim otherwise. Re-entry is always difficult, especially if you got hematoma. So my advice for maximizing the success is to use a kite extension to minimize the hematoma. And then before trying to re-enter, to try to aspirate. And then once you aspirate, you may drain the hematoma, expand the vessel, and then that facilitates the chance of successfully crossing through that area.
see, actually, Bulakis, can you just explain about the Carlino technique?
Sure. So the Carlino technique is named after Mauro Carlino, who is an interventional cardiologist from Milan. And Dr. Carlino, what he did is in early stages, building on the technique called STAR. So Antonio Colombo was the first one, 2005. He published that push a knuckle wire all the way down until it gets back spontaneously. So Mauro Carlino took this a step further. Instead of pushing a wire, he took a microcatheter, a small syringe, and injected contrast, and that contrast did the dissection. Now, what he learned is that if you inject too much contrast, bad things can happen. So in the current form, Carlino technique is a technique you use by injecting a small amount of contrast, 1 to 2 cc's, through a microcatheter, and you do this in the following situations. First, you are in the subintimal space and the wire doesn't penetrate. So it can help you kind of modify the plaque and see what's going on. The second is you don't understand the anatomy. You're subintimal, you don't understand which way the vessel is going. By doing the Carlino technique, you might make a microchannel, or the subintimal contrast can help you see which way to go. Having said that, if you do too much, that can compress the true lumen and make it harder for you to re-enter. So Carlino technique is a useful adjunct, very complex cases. Take a microcatheter in subminimal space, inject 1 cc, and then you go back and try to wire you with your guide wires.
But we should be careful about not injecting too much. Use maximum of 2 cc syringe and all. This question came in 2 days.
That's right. Under cine, so you can see it exactly. Go very slow and a very small amount of contrast.
What is the chance of perforation in those cases?
Chance is very small. Mauro Carlino has published his cases. The chance is very low. Now, you don't perforate from the contrast, but if the question is what happens before you get the contrast in. If you perforate with your wire microcatheter, then obviously that's not going to do anything to you. But just injecting contrast, in most cases, won't perforate, with the exception if you have it in a small branch. Now you are pushing a lot of dye, then you can perforate that small branch. And that's why it's very important to go very, very small in the volume of contrast.
I think due to the lack of time, we will go to the next presentation by Dr. Chin, actually from Singapore Heart Institute, and he will be presenting his case. Dr. Chin, please.
Oh, hello. Hi. Thank you very much for the invitation. I'm just going to try and share my screen. Are you able to see my presentation?
Perfect.
Yep.
Yeah. Okay, great. All right. So thanks again for the kind invitation to join this really very educational session so far. I'm Chi Tang. I work out of Singapore at the National Heart Center, and I do intervention and CTOs maybe about 10-20% of the time. So these are my disclosures. And what I'll do today is really in keeping with the theme of kind of complex intervention is, I think we've seen a lot of brilliant cases already so far. Dr. Kumar has given some really brilliant cases, and Dr. Vilakis obviously has given lots of tips. And so I'm going to talk a little bit about something that maybe is not so successful. So this is my case. It's a late 50s gentleman. He presented basically with anginal type symptoms. Past medical history, not very remarkable. This case was done about 2 or 3 years ago, so that was about 15 years previous to that. He had some balloon angioplasty to the mid-RCA, but after that, really not much ischemic heart disease issues. ECG at presentation showed AF, and the echo showed an ejection fraction of about 30%. So my colleague arranged for him to have a CT angio, and the CT angio reported something along the lines of severe proximal RCA disease, a near total occlusion. They weren't very sure on the CTA. So he was electively admitted for a cath with a view to PCI. So actually this is my colleague's case. He started it first. And then later on, I joined in just to make a mess out of it. So these are the shots of the left side. And you can see the left-sided vessels are generally okay, but you can appreciate that there are some collaterals going to the right side. More shots of the left, and you can see in the epicranial view on the left projection that there are certainly some collaterals going, filling the distal vessel. And as Dr. Vilakis has alluded to, the quality of the distal vessel obviously is important. And in this case, it looks like there's really something quite juicy to be aiming for. So these are the shots of the right. And it looks like there's an occlusion. Is this a total occlusion? It's not entirely clear. So this was done from the radial. And so my colleague decided that this probably was maybe a subtotal occlusion, reasonable chance, perhaps some antegrade flow. So he decided to go ahead and do some ad hoc PCI. So this was he chose a 6 French GR4 guider, and the plan was to, as we have already talked about in the last few presentations, was really to start off with an antegrade approach. So to get the microcatheter in the correct area with a fielder wire, and then swap out for an XTA and try and cross with that. And so this was when the guider was put in, and the guider did not sit so well. And then you can see now that the conus actually fills up very nicely. And you can see that there's really very nice cardio collaterals filling out very nice mid-distal RCA. So not a very long occlusion, but this kind of raises the issue of whether or not this was a subtotal occlusion or whether it was a true CTO. So nevertheless, he stuck to the plan and did some wiring, and the wire kind of stayed there. Wasn't very sure where it was. He got the microcatheter quite near and took a puff, and still not entirely sure whether there is a track. So he decided to persist with some intervention, with some probing with the XTA wire. And actually with some manipulation and some redirection, and after a few tries, actually he managed to get it across. So that was all very nice. But perhaps you can also see from this view that you can see the guider is not really sitting very well, doesn't really provide much support at all. But still managed to get the wire across. So the wire was directed into the right track. You can see it very nicely from those collaterals from the conus branch. And he tried to progress the microcatheter. But unfortunately, the microcatheter couldn't progress. So he took a 1.0 balloon out and started doing some leopard crawl technique to try and pass that 1.0 balloon. And very, very slowly, he made some progress. And you can see the 1.0 balloon has gone past the occlusion, and there's some dilatation involved. And this is after the 1.0 millimeter balloon leopard crawl. So at this point, he decides, so we exchange the wire and does some further balloon dilatation with a tool balloon, and then stents. And then now you can, I think perhaps some of you may have appreciated that there was this staining after the 1.0 millimeter balloon leopard crawl, almost certainly because of the buckling of that wire, as with all that force trying to push the balloon across. So you can see it in this projection already, both probably a bit clearer in the RAO projection, but certainly visible in both projections. So this is when I got involved and spent some time staring at this, and he was weren't sure what to do about this, whether we could leave this alone. And the patient was doing fine. The patient was okay, hemodynamically very stable. We did some serial echoes, looked all right, and so we decided to leave it. And we went for our cath lab meeting, and about 3 hours later, they called us up and said this guy was giddy and he was hypotensive, and we knew obviously that we should not have left it. So we rushed him back to the cath lab and got a drain in because the echo obviously had shown tamponade. And like Dr. Brilakis has already alluded to, you need to have your gear ready just in case you need to do something about this. And in this case, this distal wire perforation had indeed not stopped, and so significant pericardial effusion with tamponade physiology. We went ahead and implanted a couple of coils and managed to control the bleed, and the patient was okay and was discharged a couple of days later, and still doing fine, and has really not suffered too much from this insult. So that's one of the cases I would like to share. So we also checked the collateral circulation from the left because it's important sometimes with all these perfs that sometimes they are fed from the collateral circulation as well, and you can see that this is actually well contained. So the learning points here really, I think is as was already mentioned in that first talk about the 7 key points, is really to do your CTO PCI with lots of planning. And I think ad hoc CTO PCI is really something that you should only do with much caution and really at your own peril, because assuming that something is easy is not always the case. I think planning your support is very important. I think in this case, because the support guider was not good, there was a lot of difficulty passing the gear across, and that meant there was a lot of force, and the whole there was not enough care placed in looking after the anti-grade wire. And of course, it's not just the CTO that matters. It's fine just to open up the CTO, but you got to take care of everything, and really a low threshold to not leave anything behind. And I think this case also highlights the importance of post-procedure monitoring as we move more and more towards day surgery cases. I think really it's very important to always bear in mind that in some patients, really probably we should keep them in hospital for a while and just make sure that nothing's happening before they leave. So this is actually taken from an article that Dr. Brilakis authored, and really it's that algorithm for coronary perforations. He's actually alluded to this already in his talk, so I'm not going to cover this too much. And in the next few minutes, I'm just going to quickly present a second case. It's a late 60s gentleman with triple vessel disease, LAD and RCA CTO, and we decided to try and do the RCA. And so you can see this is the bilateral injections and really quite a long RCA CTO. And the plan was to go antegrade with a field XCA on a microcatheter, but we were not able to find the true distal lumen. So we quickly swapped out and decided to go for ADR. And this is the Stingray in a pretty good position in the distal RCA, and we made a nice stick, and then we swapped out and managed to get the wire into one of the distal branches, and then we exchanged the wire out. And then this is us pulling out the Stingray balloon. And you can see once again, this is something that has happened a few times. You get so excited that you manage to get everything through, and then you see when we were pulling out the Stingray wire, you can see that this distal tip has migrated. And unfortunately, once again, you can see that there's a blush there. So there's been distal wire perforation as well. So for this case, we stented, and we decided not to leave it alone because that blush was still persisting over there. Patient was otherwise hemodynamically stable. So we went ahead and implanted a couple of coils and controlled the bleed. And this is how we ended it up on that day. And I have to say that there was so much effort put into this, and it looked really horrible at the end. We managed to put in so many stents and really not a lot of good distal runoff, and it was pretty disappointing. But luckily, when we came back a month later to do the LAD territory, actually a lot of it had recanalized, and you can see that there's probably quite a decent amount of flow. And I think that was probably worth the effort with the recanalizing this RCA. So really, that's all I have for today. Just a couple of short cases, just to give a different kind of flavor to the whole concept. We frequently are successful, but sometimes we are not completely successful. And I think knowing how to spot complications and managing them appropriately really is also very much part of the care that we need to have when we do complex intervention. So thank you very much again.
One question to you. Basically, the first, when you pass the first case, actually, when you pass the wire down, I was actually thinking that you have to de-escalate the wire. When you recross the wire after, sometimes people should understand that when you cross with the tough CTO wire, if you de-escalate the wire to a normal workhorse wire, then this problem may not happen. But this perforation is part and parcel of our CTO intervention.
Yeah, I think that you're absolutely right. I mean, the first rule is once you cross, you need to get your microcatheter across. In this case, we couldn't get that microcatheter across, which is why he had to use the 1.0 to do that leopard crawl technique. But you're absolutely right. Looking after the wire is very important. I think some people believe that once the wire is knuckled, then it becomes safe. That's absolutely rubbish. It becomes probably even more dangerous once it's knuckled.
Manos, any comment?
Yeah, I'd like to congratulate to Tang. I think these are phenomenal cases. And I think what you saw in the first case, we see quite often as well. Many people leave sometimes the perforation. And as you saw in that case, sometimes that can lead to late effusion. So I think the small vessel perforations, as Dr. Tang showed very nicely, they can leak so slowly that even if you do an echo at the time of the procedure, things look okay. So one way to potentially prevent this is, or at least monitor them, is if you decide to observe them, is number one, to reverse the heparin, if you give a heparin with protamine. And the second one is to potentially get an echo an hour or two afterwards, so relatively soon. So if you start seeing an effusion, then you know that maybe something is not right, that you can take care of it. But I think what was done is very nice, and it was great that they were able to close it with coils. Now, the third point is sometimes you can use fat for very distal vessel perforations. But I think coils maybe give you a little more control, and when it's a really small vessel, so that may actually work well. And just if you can remind me, what was the wire again that perforated in the first case? Was the polymer wire or?
Yeah, it was a XTA.
XTA, okay.
Yeah.
As you said, the polymer wires are more likely to cause problems. And even if they loop, you're absolutely right. Even if they loop, that doesn't mean necessarily they're safe, because actually if they exit, they make a bigger exit hole than they would otherwise.
Yeah. Can I just chime in with a quick one? So from, I absolutely agree with everything you said, but like you said, sometimes we do leave these things and we somehow get away with it. Do you have any rule of thumb, which ones potentially can be left alone, or do you think all should be done? Because that's really the top, that's actually my topic, to leave or not to leave, because sometimes it's hard to figure it out,
I'll tell you, there's no hard data. I'll tell you my personal opinion. If I have a perforation like this and I'm thinking of leaving it, first of all, if it's bypass, I would seal it. Bypass, I don't want to get in touch, because bypass will have this loculated diffuse. So bypass, I would always close it with a coil or whatever you want, but make sure it's hemostasis. Now, let's say you decide to observe it. What I would do is take the wires out, reverse on the table, and wait 10-15 minutes, and then see if there is still ongoing bleeding there. So if I still ongoing bleeding, then that changes my mind. Maybe I should do something about it. But so before the patient leaves the room, then I will want to have confirmation geographically that actually the ceiling has closed. If there is still some oozing, then what I would do is, and I'm still kind of the fence, okay, maybe I would do an echo in an hour or two. And if the echo starts showing an effusion, then I will bring the patient back. But you're right. I don't think there is any, there is no, no right or wrong answer there. It's more of an opinion and
actually, Manos, I just want to tell one comment, because this staining is persistently seen and the staining is not cleared fast, then you can think that this is actually a contained perforation, and you don't have to worry about that too much. A staining is actually not very much fading very fast, then you should be very careful about that. And most of the time, the heparin, what we give, creates a perforation and problems by 3 hours. And 3 hours will be the peak time. If there is nothing happens after 4 hours, you can be sure that you are in a safe level. I think, Chin, it was a wonderful case, and we will go to the next presentation by Dr. Ravinder Rao from uh, Jaipur, and he is actually one of the most aggressive structural heart disease guy. And he actually, I never knew he's an excellent coronary interventionist also, but I was always thinking he's a TAVI guy. Dr. Ravinder, please, for presentation.
Dr. Pratap, good evening, and good evening to all the experts out there, and thank you very much for having me. I'm learning from you, Dr. Pratap. I keep listening to your CTO cases and CTO things which you're showing. So without wasting any further time, I'll go ahead and share my screen. And can you see my slides? Can you see the slides?
Yes.
Okay. Yes. So 81-year-old lady presented with ACS, non-STEMI, hypertensive, not a diabetic patient, normal LV function. She was on anti-anginals for past 2 years, and she was doing fine in terms that she was doing her daily activities. But now this time she presented with non-STEMI. Angiography showed proximal LED 90% calcified stenosis, LED diagonal 111 lesion, mid-LED CTO, circumflex OM1, 70% stenosis, 50% lesion in the, that's ostial RCA, and 60% lesion in distal RCA. Turned down for cabbage because of her age, both by the patient's family as well as by the surgeon. And the plan was to do a rota PCI of the LED CTO. So I'll play these pictures, which shows there's a proximal ostial RCA lesion, some lesion in the distal RCA, and TIMI3 flow. Here you can see a heavily calcified proximal LED, a diagonal which has a Medina 1-1 lesion, and a CTO of mid LED. There's a septal which arises from the proximal cap. We took a dual injection, which again, not a good picture from the left injection, but you can see septal collaterals filling the distal LED. Then again, a dual injection in the LAO view. And this is the picture. This is just a still frame from the proximal LED. There's a 80 to 90% stenosis from the proximal LED diagonal Medina 111 lesion. There is a mid LED CTO, heavy calcification of the proximal LED. The length of the CTO is around 1.6 centimeters. And then you can see the distal LED which fills from the septal collaterals. And also there is an epicardial collateral from the diagonal which arises and fills the distal part of the LED. This is another RAO picture which gives which defines the LED CTO segment. So the plan is dual axis. Dr. Pratap, do you want me to continue going on with the presentation? Okay. So the plan, my plan was to take a dual axis 6 French guide, fielder fine cross, and then upgrade to a Gaia 3 wire and use a rotablator 1.5 for the proximal mid and also for the CTO segment of the LED, 2 stents and provisional for the diagonal. This is the fine cross which I have advanced with the help of this is a Corsair which I have advanced with the help of a fielder wire. And then I use a Gaia 3 wire without using the pre-shaped tip only, not to make any additional tips, bend to the Gaia 3 wire. And the reason I used a Gaia 3 wire here is because this portion of the CTO segment was a straight portion, and instead of Gaia 2, the Gaia 3 will give me more support because this is a chronic total occlusion looking at the entire collateral systems which is filling. Also, the calcification, the proximal mid LED tells me that there might be calcification even in the CTO segment, though it is not very evident on this thing. So here you can see I've crossed with the Gaia 3 wire into the distal, crossing the distal cap and into the distal LED. But the challenge which was happening is I'm not able to enter into the almost at the apical part of the LED, and that is because of a hairpin turn which is there in the distal LED. And you can see here this turn, and the Gaia 3 in my mind, if I try to negotiate through that turn, there is a high possibility that this will dissect. Then I tried crossing with a 1.5 balloon, but the 1.5 balloon did not cross. So the challenge was the fine cross, the Corsair never crossed, the 1.5 balloon did not cross, and then I could have tried with the 1 balloon, but what I thought is because of this calcification, calcified proximal cap, the balloon is not crossing, so I jammed my Corsair as distally as possible in the CTO segment, and then I was successfully able to wire directly with a rota wire. Then I confirmed the position of my distal tip of the rota wire, and here I can see it is in the true lumen. And then I use a 1.5. You can see here the wire, how it comes to the epicardial collateral. This looks too far, but if you look at the angiogram, there is an epicardial collateral which comes from the diagonal, then and the wire is there in that collateral. So I did use a 1.5 burr, did a burring of the proximal LED because that was a very heavily calcified tight stenosis. Once that was done, burr, then I burred the CTO segment of the LED. And this is the angiogram after doing a rotablator burr of the proximal LED, mid LED, and also the CTO segment. So there is some doubt that there is a dissection at this part of the LED, but I think there is a competitive flow. Still the antegrade flow is not equivalent to the flow which is coming from the epicardial collateral here. So this gives a false impression that this might be a dissection, but let's see. Then I wired a fielder wire parallel to the rota wire. And this is pre-dilatation using a 2.5 NC balloon starting from the distal LED, mid LED, and the proximal LED. And this is the angiogram after doing a pre-dilatation. So you can see good TIMI3 flow in the LED, but the diagonal has plaque shift and almost 80 to 90% stenosis. Then did a dilatation of the diagonal using a 2.5 by 12 NC balloon. So next, my strategy was to use 2 stents in this patient. This is a 2.5 by 48 millimeter Zion stent, which has been deployed at nominal pressure, pulled back and deployed at 14 atmospheres. Next is a 3 by 28 Zion, starting from the proximal LED, overlapping with the stent thread deployed at 14 atmospheres. And then post dilatation of the entire stented segment. And then did a kiss to the diagonal, achieved a TIMI3 flow, but the portion of at one point of the LED, the stent was still under expanded. I did an IVUS post procedure. I can play the IVUS video if there is time, but at one point the LED, mid part of the LED was not fully expanded, and we could see how the stent was not fully expanded, not fully exposed. However, the MLA of the proximal portion of the LED was 8.46. To me, this was good MLA for this LED, and I use an Opian balloon to open that segment, 3 Opian balloon at 35 atmosphere to post dilate a small segment in the mid LED, and then I use the same balloon to again go up till 35 atmospheres in the proximal LED. This was the result post dilatation using an Opian balloon. And this is the same view in the RAO caudal view. The plan for the residual CAD is because she's 82-year-old, I'm going to again manage her with medicines. And if she still continues to have symptoms, we would do a stage PCI. But the challenge in this particular patient was my 1.5 balloon not crossing, the Gaia 3 wire, 2 heavy duty wire to actually take that bend in the distal LED. It might have perforated. And I think I got lucky that I was able to wire directly with the rota wire. I'm open to all discussion and inputs from all the experts.
I think it was a great case, Ravinder. Basically, it was a great case. So there are 2-3 comments I just wanted to make you. When you take a rota wire in a very tortuous anatomy distally, there is a chance of perforation. That is one thing to be remembered in this case. And why you did not do a granuloplasty with a 1 millimeter balloon when you are wire?
Yeah, I agree. So I could have done that. So that's why I'm listening to you. I could have done that instead of doing a rotablator. I could have done a granuloplasty with a 1 balloon. But again, I was thinking, I've done this in few cases, but I have been unsuccessful. I don't know why. I've done granuloplasty, but still my bigger size balloon never crossed. So yes, that would have been an option, that I would have done a granuloplasty. And then
another doubt is when your balloon is not crossing, you can keep another wire into the diagonal branch. You keep a wire there with an anchor balloon technique. You can take the smaller balloon down through the CTO segment. That is one choice. Let me go to Manos. Manos, comments, please.
The only reason I use a rota wire in this is because I had to use the rota for the proximal and mid LED. So I thought, because if I have to use the rota and for proximal mid LED, I might use it for even the CTO segment. But yes, I'm open and for all the discussions.
Manos, any comments?
Yeah, no, Dr. Rao, that's congratulations for an excellent, that was a very complex case and was done very well. Regarding the point that Dr. Kumar brought about the balloon uncrossable. So, I mean, actually what you did is very neat and very elegant. There are other options, as Dr. Kumar said. I mean, the typical thing is try the 1O balloon, which you did, then rupture if it doesn't work. And then if that doesn't work, another option to consider is potentially putting a guide extension or doing a side branch anchoring. Now, this is a diagonal. You could potentially use side branch anchoring on the diagonal. The other option that comes after that is to, before pulling the wire back, if you have it, is to use laser. And I don't know if you have it in your sender, but laser might be able to get through this without losing your wire access. But if that doesn't work, then what you did, actually, it's a beautiful technique. You get a microcatheter as far down as you can, and then you wire with the roto wire, and sometimes it works. The only downside of this is that if it doesn't work and then you lose your access, then you may have to recross that CTO. But clearly, very complex case, and there's no right or wrong answer, but it's good to have an algorithm as you do, and these are different options depending on equipment and the specific circumstances. And then very nice job on the bifurcation as well, getting an excellent final result there.
Thank you. My question to you, Dr. Pratap, and to you also, this diagonal is giving a huge epicardial collateral to the distal LED, and the diagonal also supplies the huge area of myocardium and the lateral segment. Would you be comfortable in anchoring a 2.5 balloon in such an important vessel?
To me, if you ask, I think it is not a big issue, because you just put an anchor balloon and just keep the balloon, track the balloon down to the CTO segment, deflate the balloon and take it out. What is a big issue? Number one technique, I just want to tell one more technique which can be used. If you take, nothing is crossing, even the CTO, your wire rota wire you could not take, and you are in a trouble situation, you can take a retrograde wire through the diagonal, go back into the LED, recross into the catheter, and through that you take a rota wire and then come back. That is one of the choice. I think Manos, if any comment is there? Final comment?
No, yeah, I think it was very well done. Again, multiple. I mean, the other point here is that complexity begets complexity. Here you have a CTO, you have balloon uncrossable, you have a bifurcation. So when you tackle this lesion, you should be ready to tackle a variety of challenges. And you never know, in a case, you may have a bifurcation, you may have the uncrossable. So it's good to have all the tools and the algorithms in your head to tackle these situations if they arise.
And thank you, Manos. Thank you, Ravinder. We will go to the next presentation by Dr. Gopi.
Thank you.
Thank you. Actually, who is the director of Fortis Hospital in Bangalore. Gopi, please, for your presentation and your valid points.
Yeah. Good evening, everybody. Thank you for having me here. So I'll just share my screen.
Chiranjeevi, can you Ravinder, can you just stop sharing your screen?
Sure, I will do that, sir.
No, from yes.
Gopi, now you can share.
Share screen. Is my screen visible now?
Yes.
Very well.
Yeah. So yeah, good evening. So there's a long CT of the RCA. This patient, 67-year-old male, had undergone a bypass in 2006, a known hypertensive diabetic, came in with chest pain, troponin was positive. There were no specific ECG changes. So we managed as ACS and took him up for a diagnostic angiography. In that, we saw that his graft to the RCA was occluded. So then we took him for an angiogram, and since the RCA graft is totally occluded, and we knew that the RCA was also totally occluded, he was stable. Managed him conservatively and brought him back for the angioplasty to RCA. Sorry. So this was the bilateral injections. It had a long occlusion from the proximal up to the bifurcation. Planned an anti-approach in this patient. This was done about 4 to 5 years back. At that point of time, was not too familiar with the retrograde, so I didn't have too many options. I had to only plan for an antigrade approach. The vessel was heavily calcified. The JCT score was 2 because of the severe calcification and a long lesion. Now, another view showing the calcification. But what you notice is that in this mid of the RCA here, there is some sort of stain that fills up. So I knew that there was some lumen in the midway between the RCA also, where if I could get this as my first target, and then from there take the wire forward. So that was the plan. Again, showing another view showing the severe calcification. So started off with a fine cross, catheter and Amplatzer wire. Used the Fielder XT, got into this position initially. Then at all this time, when I was trying to move to get the fine cross any further, then managed to get the guide wire up to this location that was almost up to the bifurcation. At this point, it did not appear to be in the vessel, at least distally. Then again pulled the wire back, made multiple attempts. At all times, it felt that the distal wire, I could not cross the distal cap. Again, you see over here, it did not seem, I was not sure whether it was in a side branch or it had actually crossed, but I could not just take it into the PDA as that. So at this point, I decided that I'll try and work on, getting my microcatheter much forward, and then, escalate the wire. So that was the next plan. Actually, it took me, I had a lot of difficulty in getting the microcatheter up to this position. I did not have a corset at that point of time. Exchanged the microcatheter for a 1.25 balloon, dilated a little bit, took that back, again took the microcatheter. So multiple times I had to do these exchanges and got the microcatheter to this position. After that, the next plan was I thought I'll use a miracle wire. So got a miracle, 6 wire distally. With this, somehow I did manage to cross into the PDA. Then again had difficulty in getting a balloon across, because my plan was I'll take the microcatheter into the PDA and then chain the wire so that I could work much more comfortably and safely. Had to do multiple dilatations all along the artery using a 1.25 and 2 millimeter balloon. And then luckily after that, so now the balloon has reached up to the distal RCA. Then now you see that I could finally get the microcatheter into the distal RCA, and then I exchanged the wire for a regular workhorse wire. So this is the workhorse wire in place. Had to do multiple dilatations. Luckily, probably a lot of the calcium looked, maybe adventitious, so I did not have as much difficulty as I thought what I would have. And then, so finally did multiple dilatation. This was what the angiographic picture I got before planning to stent it. Again, distal RCA, there was still a persistent lesion, dilated that, and then then I was ready to stent. This is a 2.75 into 48 millimeter Zions expedition stent that was deployed. Then following that, proximally, I did a 3 into 33 millimeters Zion expedition stent. Again, post-dilated with a 3 millimeter through. This was the final result that I got. I mean, the PLV also, was well preserved, and I thought I could, it was good enough for me to accept this as a result. So this was the final results, and so the take-home messages were hardware selection is an integral part of CTO PCI planning. In this case, a long 7 French sheath and an Amplatzer guide catheter was very much instrumental in success of the procedure. It gave me very good support. The calcium actually guided me to stay in the vessel with the guide wire. And at times, calcium has its advantages so that you know exactly where you are. Thank you for the attention.
Once again, a wonderful case. Basically, it is actually a wire crossed, uncrossable CTO with a lot of materials to be used, multiple exchanges with small balloons, then finally reaching. But Gopi, I have a doubt. If you actually cross the lesion, nothing is crossed. You would have taken a rotator and did the procedure in the middle part of the RCA, which was looking like.
That was the plan actually. If nothing crossed, I would use a rotablator as that. But I mean, luckily it didn't manage to cross, so I think I didn't have to get into that.
But if you would have put one more wire into the PLV after you are crossing, when you're stent crossing, it would have been very easy. But you just managed everything with one wire. Do you think that you would have put one more wire into the PLV and then it would have acted as a buddy wire for?
I think I didn't reach a stage where I was, where I felt that it is not happening. It was happening very slowly. So, I just was patient and could work through it. So that would have been other options if it was difficult as it.
Okay. Manos, please comments. Manos.
Yeah, again, congratulations, Dr. Gaur. That was a great case as well. I think for me, this shows some of the challenges for calcium, which you said it was challenging delivering everything down. But also, you did have the bifurcation on distal cap. That's always a very complex issue. Now, many people recommend, if you have a bifurcation distal cap, to go on a primary retrograde approach, which has a plus and minuses, but the retrograde, as we know, does increase the risk of the procedure. And I think your case very nicely illustrates that you can get some of those cases done just by going undergrade in a very careful and well-designed and well-performed undergrade escalation. I agree with what Dr. Kumar was saying about using a dual loop microcatheter to protect the side branch. But I think overall this was very well done. And I think, again, that reinforces the point that wire escalation remains the #1 for most CTOs. And then if it fails, you do other things. But it's better to start with the less aggressive and safer techniques than with the more aggressive and potentially more risky techniques as well.
Manos, will you do IVUS in these cases before you plan for a stent in the last point? Because we will not be understanding or underestimating the size of the stent. We may, and because he put a 2.5, I think Gopi put a 2.5 into 48 stent, right? Distally?
2.75 and 3. 2.75 distally and a 3 mm proximally.
I think the imaging would have gone a little more higher, I personally think. What is Mano's comments?
Yeah, good point. I think, you're going to do IVUS if you can. Now, IVUS will not help you because of the small distal vessel, because the reason the vessel is small is because it's shrunk over time. So IVUS will still show you a 2.5 vessel, but then you have to take into account how much can you stretch it without dissecting it, because as you know, it's going to grow by 0.3 to 0.5 and more sometimes millimeters over the next 2 to 3 months. So IVUS is helpful, but again, sometimes the vessel is just chronically underperfused and becomes small, and then IVUS will not help you in that circumstance.
But we do IVUS in multiple dilatation. We do 2.5, 2.75, repeat IVUS, and then only assess what is the size of the stent can be used. That is actually one way we try nowadays. Earlier, we just try with one IVUS and then decide. Now we do multiple balloon dilatation, then do repeat IVUS. and then take a decision of putting the stent. Because the vessel PD and PLV look like 2.25, 2.5 vessel. So by Finet's law, it should become minimum 3.5 vessel, this proximally. That is what I was thinking.
No, so I think you use the IVUS both to size, but then after you put the stent in, you to check the stent is expanded well and opposed well. So you use it on both ends of the procedure.
Yeah.
Okay.
Thank you, Gopi, and thank you, Manus. We will go to the final presentation by Anand Janraj. He is actually a very aggressive CTO operator from Chennai, and is a colleague. And Anand, you can come.
Yes.
Please.
Yes, thank you. So I will go to my screen share and just give me a minute. Can you hear me?
Do you able to?
Can you hear me?
Yeah, I can hear you.
Okay. So.
Can you screen share any problem? Okay.
Yeah. So I'm presenting a case of an RCA CTO, which by itself was quite difficult with a distal LMCA, with a osteal LMCA disease. And then that procedure looked very simple when compared to the problems that followed. This was a 62-year-old diabetic, obese guy with chronic stable angina for more than 6 months. Was advised CABG in multiple places, but absolutely not willing to go for CABG. Normal LV function, calcified RCA CTO, and critical LMCA disease with proximal LAD disease. So you can see this was the right. A short segment CTO, but then the entire vessel was diseased. I had kept a wire in the left because there was a very critical LMCA osteal disease. So I didn't engage, just kept the wire only for injections. You can see the osteal LMCA there. It's just a pinpoint LMCA with the proximal LAD disease also. So initially I started with the Fielder FC wire, crossed without much difficulty, but as you can see that I had to use an anchor and how much the guide is backing out because I'm trying to push the corsair through that segment. Then the wire got stuck in the corsair. You can see that the tip of the corsair is completely flattened out, and I had to pull out the entire thing because you can see that the crushed segment of the corsair is holding on to the wire. So we had to kind of discard both and then start all over again. And again, the wire crossing was not difficult, but this time I didn't take a corsair. I just took a 1.25 into 6 balloon and tried dilating the proximal segment. Like you mentioned about granuloplasty, this case was a typical multi-granuloplasty. So you can see that the first balloon is ruptured and created some planes in the intimal layers. Then this was the second balloon that ruptured. Then I took the third balloon, which was a 1.5 into 12. Again, ruptured. I could have taken a Tornus and taken a rota catheter, but I didn't do that. Now, this was the fourth balloon. It was a 2.0 balloon. Again, it ruptured in the proximal segment itself. But the nice thing was once this ruptured, there was a nice multiplane lumen that was created by the rupture. So beyond this, I was able to pass the balloon down. So we started with a 2.012 balloon dilatation from below. And again, that balloon again ruptured because it was a terribly calcified vessel. I truly regretted not having taken the rota, but because the corsair got so crushed, I just didn't think about the rota wire. Should have taken that down and this would have been much easier. Then of course stented down with 2.5 into 34. Then again with a 2.75 into 34 again. And then proximally with a 315. So all looked well, but I think the looped wire had caused a dissection at the crux. You can see some staining there in the PLV side. So I rewired that part and had to stent again into the PLV to take care of the dissection. So finally that came out well. And then I did the left main and LAD in the same sitting, which went quite smoothly. It was not too difficult. So we put a 2.75 into 24 in the mid LAD and 3.5 and 3.528, I think, in the left main to LAD. And finally did a pot. Circumflex had mild moderate disease, but nothing worth stenting. So post dilatations, everything looked good and the patient was discharged. And the second episode started after 6 months. First procedure was in July 19. You can see the second was February 2020. A pain at rest, initially managed with nitrates, then not responding. So I took him up, again advised surgery, but again not willing. And this was the angiogram. The right had a small lesion in the mid segment. Ostium of LMCA had again stenosed. And of course, the circumflex had developed an ostial lesion and an OM1 lesion. These two were probably de novo. Circumflex ostium was probably related to the first stenting. So now again, patient was not willing for surgery. So I stented the OM and then dilated the LAD and left main. Put a stent again of the same size, 3 into 30 size in the LAD, and put a short stent in the circumflex ostium. This was a 3 into 8, and another 3.5 in the LMCA, and did a kissing balloon also. Again, looked good. Patient went home again, but this time the restenosis time became shorter. Came back after 2 months. This was February 2020. He was back in April 2020. Again, rest angina for 2 days. Took him up for an angiogram, and this is what it was. That OM branch that I had stented developed restenosis. So this time I thought we should do a DEB rather than re-stent inside the OM stent because it was such a short segment. So I did IVUS to make sure that the LAD and LMCA were okay. LAD and LMCA were fine. The diameters were quite good, areas were good. So I didn't touch the LMCA and LAD and did a DEB for the OM. Now the result looks very good. Absolutely, patient was asymptomatic and went home happily. Now, if you can see the LCX ostium here, already it was slightly narrowed. But I really didn't want to touch it because I thought it might stop there because it was done about 2 months before this. Then again, episode 4, patient came back 1.5 months later. That was 2 weeks back with rest angina. And this time patient knows what it is. So he comes straight and says, I want angiogram. He's really reluctant to do anything else. So he had an ostial circumflex restenosis. Right side was okay. LAD, LMCA was okay. OM was relatively okay. So again, I put a 312 stent in the circ ostium and dilated the OM ostium also. So when I dilated the OM ostium, the lower branch got pinched, ostium, you can see that. So I had to do a kissing there. Now I'm quite sure that that's going to be the next site of return. But this patient is okay. Current status, patient is fine, asymptomatic, still enthusiastic about PCI. LV function is still good. The only problem is I'm kind of depressed. So otherwise, this was one of the best challenging cases so far. Not sure how it is going to go in future. Thank you.
Ganraj, a lot of learning from this case. But my small doubt is why you did not try an imaging minimum in the second time, you did not try third time. I did not understand why the imaging was not a choice to understand what is the cause of ISR, what is the status of the vessel size, whether it is a real malposition or something like that. I just wanted to understand.
Yeah, I didn't do it because I initially thought it was a very straightforward ISR, and I think they had another thing was they had dropped the IVS machine on its face and broken the screen, so we didn't have it on that day. And this patient came suddenly, so I could not organize it also. So I thought many times, and I said, okay, he is unstable angina, pain at rest. So I didn't want him to have the left main occluded. So I just went ahead and put a 3.5 stent again. I think looking back, I should not have touched the circumflex ostium or OM the second time. Though it looked, because I was not sure which one was causing the ischemia. I think it was the left main ostium rather than anything else. But in a little bit of a panic, I stented the ostium of the circumflex and the OM. Now that is coming back and again and again. The LMCA and LAD are fine. So that probably was a mistake.
Probably if it is coming back again, you will be doing an imaging and understanding what is happening.
Meaning? BEB? No.
Will you do an imaging again? Imaging will be your choice next time if the patient comes back.
Yeah, I've already done imaging of the LAD and LCX.
Okay.
There is one part in the LCX which is quite calcified, which I've expanded now with a second stent. The such branch that has got pinched, yeah, I should do an IVS, but I'm really not sure where the help is going to come from. He already has, I think, 12 stents by now. So let's see.
So Janraj, actually there was a comment from one of the audience actually asking that in the first sitting, why you did not do an LM stenting first and then try RCA later?
I'm quite skeptical about touching LMCA with an occluded RCA. With a normally flowing TIMI3 flow LMCA, I would definitely try RCA first, because in the event of a slow flow or a dissection or any complication, patient dies on the table. So I would give it a shot first.
And actually, initially you told there was a tight ostial disease in the LMCA. That is what.
Yeah, there was. Yeah. So I didn't engage the catheter. So I kept it outside. I was ready to stent at any time, but I wanted to try the RCA first. And since the wire crossed, I was quite optimistic. But unfortunately, it became much more difficult than I thought.
Then later you thought it would have been rotablator would have been a much better choice and just finish.
Yes.
Manos, comments, please.
Yeah, first of all, I want to congratulate Dr. Ganaraj. I mean, that was obviously an extremely challenging case, but it was handled in a very expert way. So congratulations again. This is a very, very complex case. I think for the issue of in-stent stenosis that you brought up, I mean, it is a challenge. We know that, when you do multi-vessel PCI in diffuse disease calcified vessel, this can happen. So this is not outside the origin. Here are some thoughts how to approach it. I mean, as you say, imaging is a good thing if you have it available. Sometimes we give cilostazol. Cilostazol, if the patient doesn't have heart failure, it might reduce the risk of stenosis. Hard to know if it works very well or not, but in patients like this with recurrent events, something to consider. And then the other option is, and if it's available in your place, is brachytherapy. Now, there's drug-eluting balloons, there's brachytherapy. Actually, in our place, we have a resurgence of brachytherapy. For cases like this, if they have twice in-stent restenosis, then we'll bring them back, ensure they're well expanded, and then we may use brachytherapy to prevent the restenosis. So these are some thoughts. Again, hard to know which one may work or not, but I think you handle it in a very nice way. And despite the recurrences, I think you've done whatever you can to minimize the risk.
Thank you.
Janraj, a lot of people try with the DEB, especially with the sirolimus eluting DEB is available, that actually produce an excellent result in many cases. But you have to prepare the lesion very well before doing anything on that. Otherwise, this balloon may not track at all.
Okay.
I think it's a time to stop, and we actually concluding the session. But before that, I just congratulate and thank all the presenters, starting from Emmanuel Berlakis, then Khalid Tamam, Dr. Chin, Dr. Gopi, Dr. Ravinder Rao, Dr. Janraj. But I should tell that presence of Manos Berlakis made this meeting a wonderful one, and many people attracted to this meeting of his presence. And I should tell it was a wonderful day for us. And we will be coming again back next after 2 days with a case present, live case with calcified vessel with imaging is the next program on Thursday evening, 6:30 to 8:30. But I should tell that without the participants, no meeting will become a lively but excellent participation. And I should thank each one of you, because you are better than us. But only thing is you are sitting on the other side. We could not see you, and the communication is very less. I should thank everybody. And any comments from Gopi, any comments from Chin, any comments from Janraj? For the last comment you can make and finish.
Thank you, Dr. Pratap. It was an excellent program and a lot of learning, high quality cases, and the wonderful talk by Dr. Berlakis. And I hope to have much more interactions and sessions like this in future.
Yeah, likewise. I mean, first time joining a session like this all the way from Singapore. As you can tell from behind me, it's pretty dark now, but well worth it staying up for this. Thank you very much.
Gopi, comments?
Yeah, I mean, I think it was a wonderful session. I think we all learned, and with the experts, I think we look forward to more such webinars. Yeah.
A last comment by Manos.
Well, thank you all. Congratulations for the great session, and thank you all.
Thank you, Manos.